So, hello and welcome. This is the first in a series of webinars from the Institute and Faculty of Actuaries Mortality and Research Steering Committee, or MRSC, looking at post-pandemic longevity. My name's Tim Gordon. I'm Head of Longevity and Demographics at Aon, and I lead Aon's Demographic Horizons team. And a topic that is front and center for us and our clients is the impact of the pandemic on future longevity. It's always been the case that future longevity trends are unknowable, but the pandemic is not only a potential trend shifting event, but we can't even start to measure its impact on mortality trends because the pandemic is making it very difficult to observe the actual underlying signal. So given that dearth of information, the next best thing, I think, is to listen to experts discuss how they are thinking about future longevity trends. And to that end, I'm joined today by three highly respected fellow longevity experts. Matthew Edwards leads on mortality and longevity in Willets Towers Watson's life insurance practice. Matthew co-founded and co-chairs the COVID-19 Actuaries Response Group, which has been brilliant throughout the pandemic. He's also the current chair of the CMI, so good to see that's been left in good hands, and he edits the IFoA's Longevity Bulletin. Stephen Baxter will be well known to many of you. He's Head of Longevity Research and Innovation at Club Vita. Stephen leads a multidisciplinary team of statisticians and actuaries in analysing predictors of longevity, emerging trends in later life mortality, and the implications of longevity uncertainty on the financial health of pension schemes and insurers. And our third panellist, Richard Willets, has specialised in longevity research since the 1990s, when he wrote the prize-winning and very influential science paper, Mortality in the Next Millennium. He's a former member of the CMI Exec Committee and chaired the Mortality Projections Working Party, which is now a committee in itself at the CMI, which developed the original CMI Mortality Projections model. Richard now works for the Just Group as an expert longevity consultant. So our focus today is post-pandemic longevity. So we're looking at mortality from, say, mid-2022 onwards, and we want to compare that with the view at the end of, say, 2019. So we're going to discuss the drivers that may have changed as a result of the pandemic. We're focusing on that difference in view, not what drives changes in mortality rates in general. We're specifically not discussing mortality during the immediate pandemic, unless, of course, that has implications for future longevity itself, which it does in a couple of cases. History has taught us that longevity can vary massively from what at the time were very reasonable predictions. Our objective today is to have an open discussion to help actuaries and others form their views on best estimates, but let's not forget the uncertainty surrounding future longevity remains huge. Along the way, I will try to get our panelists to indicate whether the impact takes the form of a one-off hit or a drag on improvements themselves over the next, say, 20 years, and also whether the impacts vary materially by socioeconomic or age group, which in our day jobs is probably critically important. If you want to ask questions, then please do use the Q&A button at the bottom of your screen. Don't use the chat function because we won't see that. And I'll just finish off by noting that the session is recorded and will be made available shortly. So let's kick off. So let's start with COVID itself. Matthew, how do you see COVID-19 itself impacting future longevity, A, because it becomes endemic, or B, via long COVID?
Well, thanks, Tim. So interesting questions, both very topical. They're also interesting compared to many of the other COVID questions because they're both really, from my perspective, more of a base mortality question than an improvement question, which ideally would make them seem more objective, but clearly still quite a bit of subjectivity and judgment. Hence the I guess the discussion-based nature of this and the many concerns and queries everyone's got as to where things are going. So whether it becomes endemic, what happens there, and the long COVID effects. So both move in the same direction, base mortality up. So no prospect of any cancelling out there, as some of the other things we'll discuss later may be cancelling out. So on the endemic point, it always did seem to me, and well, pretty much everyone, as a long-term, if you like, aspiration that COVID would eventually wind down into an endemic, but fairly low mortality problem. The Delta variant was interesting because it showed us that a more infectious variation, a more infectious mutant, wasn't necessarily going to be lower mortality, in my view, because of the long gestation period of the virus. So it doesn't need to be low mortality to successfully sort of invade the population. But interesting, a couple of quite strong expert opinions coming out over the last couple of weeks. Sarah Gilbert and also John Bell both saying very much the same thing. I guess they're sort of probably quite familiar to each other anyway, but they have the virus turning into a common cold over the next few years, which to me actually feels slightly on the optimistic side. Not that I'm really qualified to argue against either of them. Because I've been thinking of a safer sort of medium-term view along the lines of another flu-like virus, flu-like in terms of, well, probably symptoms as well, but also flu-like in terms of mortality impacts. So in other words, in the medium term, maybe you're looking at a sort of a double flu level of mortality compared with normal flu as a rough order of magnitude, and then perhaps mitigated by things such as higher uptake of flu vaccine and maybe more risk-averse behaviour in sort of crowded places in the winter and so on. So I think that still makes me feel a bit like a sort of cautious optimist, I'd call it, which is, I think, is a good deal get from an actuary, cautious optimism. So that's on the endemic point. On long COVID, I'm also becoming cautiously optimistic, having been sort of rather pessimistic sort of this time a year ago when we started thinking about it. So a year ago, very concerned, but we've had over a year now of, if you like, empirical evidence as opposed to much in the way of sort of decent, robust studies on long COVID, as well as equivalent longer term effects from SARS. A lot of us have been looking at over the last year or so. And the green flag for me, if that's the right metaphor for sort of cautious optimism, is looking at the Q2 deaths in the UK, where we saw actually quite material negative excess mortality. So over the quarter, roughly 10,000 or slightly more than 10,000 fewer deaths than the equivalent 2019 mortality would have led us to expect. So clearly that needs to be disaggregated, and the fact that it's negative relates largely to forward displacement, which I guess we're going to look at later on. But it's a clear sign that long COVID is not seeming to be giving us a form of sort of post-pandemic, mini-pandemic for the bulk of cases, as might have been a big concern a year ago. So that's good. Been also some news and views over the last month that a lot of the long COVID suspected cases may actually just be effectively people self-diagnosing, misreporting as just having general fatigue or whatever, which many of the long COVID symptoms are themselves fairly, if you like, bland tiredness and loss of smell and so on, and hence many of the suspected cases may not be long COVID at all. I think the ONS was saying roughly half of them, or up to half of them, might be not long COVID. So it does seem to be overall, it's looking like it is a material mortality risk for those COVID survivors who've been through ICU, had a very bad time of it at the hospital level. But for the bulk of people who've had COVID, not at that intensive care level, I think it's going to be a almost immaterial thing. So overall, it could be another thing making base mortality worse, but probably less so than many of the other drivers we'll be looking at in the session. So those are my sort of basics of starter points for refutation or whatever.
Okay, so a little bit worse. So still negative compared with where we were, but not doom and gloom. Stephen, I wonder if you got anything to add? I think Matthew covered quite a lot in that answer.
Thanks, Tim. And in many ways, I'd echo Matthew's cautious optimism. From everything I've seen, the majority view in the medical and scientific community seems to be that COVID will become endemic. Hard to see it being eradicated. I think the important distinction I would draw, though, is that we often then characterize endemic as somehow the same as being like the seasonal flu. Endemic, the WHO doesn't recognize flu as being endemic. It sees that as seasonal, something that subsides outside of those seasonal months with occasional pandemics. And the kind of things that it does consider to be endemic are diseases which have much more predictability about them. Things like malaria, for example. And malaria is something which we know about how it's transmitted. We know how we can protect to some extent against malaria, but it's still very dangerous, killing 400,000 people every year, predominantly in Africa. And so for me, the question here is the extent to which we get, I suppose, saying it's endemic but benign, in the sense that it has the predictability of something that's endemic and that we're able to deal with through seasonal or annual vaccinations, through boosters and through good health behaviours, versus it having unpredictable surges and new variants, waning vaccine efficacy, etc., where an endemic virus would be much more negative on future longevity outlook. And for me, that comes very much back to the global vaccination program and the success of that. The only thing I'd remark on long COVID is I would agree with Matthew's characterisation that I think generally the flags have turned from red to much more positive colours with regard to long COVID. And for me, it's more about the long shadow that COVID is playing over future years in terms of other aspects rather than the long COVID in its clinical form.
Excellent, thank you, Stephen. So if I move on a little bit, there's been a lot of coverage of the fact that routine screening and treatments have been delayed as a result of the pandemic, with there now being a huge backlog. How do you think these could impact future longevity?
Thanks, Tim. I think for me, this is the area that's really changed since 2019. You're asking about how have our views changed, and this is for me one of the really big areas. We know we've got a fundamental challenge in terms of a screening and treatment backlog. I think as of April, articles in the Lancet were referring to more than 4.5 million on waiting lists for surgery. For 300,000 people who have been on hold for more than 12 months, a wait time that had been 100 times higher than pre the pandemic. And a very large proportion of these relate to cancer. Now, for me, this immediately points towards an issues around potentially a new generational effect coming through because of the generations that go through the screening and the treatment programs of these key diseases. And it also points, the other aspect you asked us to comment on, the socioeconomics, it also points towards a socioeconomic gradient of some description, given the risk factors for many of these diseases, and also the ability of some parts of society to access private healthcare and potentially circumvent the delays in the NHS system. For me, in terms of looking forward to future longevity, I think really the issue is this misgeneration in terms of the screening and the speed at which we take those individuals through the detection, diagnosis and treatment pathway. Taking cancer as an example, if we catch most cancers in the early stage, they're largely treatable, but as we go into later stages, they become very hard. 5-year survival rates, breast cancer, stage 1, 98%, drops to 25% by stage 4. Bowel cancer, 92%, down to 10% by stage 4. Prostate cancer, stages 1 and 2, essentially 100% 5-year survival, down to 49% at stage 4. So that timeliness of identification of cancers is going to be a really important factor. But we also need to bear in mind that this will be variable by cancer site. It's not going to be uniform across the different causes of death. There is certainly a huge amount of difference. For instance, some cancers that have much faster replication rates, growth rates. Some breast cancers, lung cancer, B1 cell lymphoma, they are ones that progress very rapidly, and we could see particularly big impacts from them in future years. But I think it's also important to realise that the screening is all about capturing people who are often asymptomatic. We've also got the impacts on the face-to-face treatments, the GP treatments that have also impacted people who are moving through the progression. And it's not just about the cancers and the circulatory disease, it's also, I think, about dementia. The likelihood is that dementia rates will dip short-term, dementia mortality, primarily because the large number of individuals, older ages, who had dementia, who sadly passed away during the COVID pandemic. But actually, medium and longer term, I fear for the wave of dementia coming through, driven by social isolation, driven by changes to our social care structure that we've seen over the last 18 months. And certainly that, I think, will be a negative wind for the next 5 years, 10 years.
Thank you, Stephen. Matthew, do you have any points to add to that?
Yeah, nothing I suppose to add in terms of being radically different. I think generally agree with Stephen that there's been more and more in the news and the medical journals about it. I suppose the good and the bad. I mean, the bad thing is it involves a lot of cancer. The good thing from an actuarial perspective is there's so much data on that we can actually make some fairly sort of reasonable models on the likely number of deaths we'd expect from the delayed diagnosis. So when we're doing some modelling of this, we're coming up with of the order of magnitudes of 5,000-ish sort of deaths from the delayed diagnosis this year, and that's a figure carrying on, but being sort of winding down fairly quickly over the next few years. So order of magnitudes of maybe 10,000 extra deaths from that over the next couple of years or few years, which actually ties in honestly coincidentally with the last sort of headline I saw on this from a sort of UCL research of around about 10,000 cancer deaths which would not otherwise have happened due to the delayed diagnoses. And of course, as Stephen said, we've got lots of other conditions as well. Cancer tends to be the main one in terms of the importance of early screening, early detection, because of the weight of the importance of getting in there early at the early stages. So overall, clearly bad news. I think it's one of these things where the numbers, you know, the 10,000 deaths over the next few years is clearly not nice for them or their families, but it's you know, compared with the total number of deaths in the UK over those few years, it's not a very large proportion. So it's one of these things which I think is seeming worse due to the headline coverage, and naturally it's the thing the media will pick up on because you know, everyone's affected either by delayed hospital waiting times for themselves or a close relative. So I think it's feeling a bit disproportionate in terms of media coverage, but it's going to be just about material sort of adverse mortality effect, but not a not a massive mortality dip just from this.
So 10,000, what I can't remember, was over the next 5 years you mentioned, which is really quite small compared with 500,000 or 600, depending which bit of the country measuring.
Yeah, well, compared with 10,000 headlines, it's
yeah. So Matthew, you mentioned earlier, and I know you're very keen to get onto the topic of forward displacement of deaths, and so it's a topic that does come up, and Stephen alluded to it as well, which is that people who've maybe taken before their time during the pandemic, but that does leave, when we look forward, potentially lighter mortality because the surviving population is more hardy. Maybe you could just take a moment just to explain how that works, and then maybe comment on how material an effect and maybe its duration.
Yes, sure. So looking back almost to the earliest months of the pandemic, one of the things I think we were proudest of in the COVID-19 Actuaries response group was being fairly vocal on this, was a lot of, sort of media coverage saying that, you know, the people dying from COVID were dying from comorbidities, they were dying with COVID, not of COVID, and so on. And when we sort of looked into this, it's fairly clear that first of all, clearly there's a very big sort of age emphasis in the COVID deaths, and most people age 75 plus, 80 plus already have a few comorbidities. So the fact they had COVID didn't mean they were dying because of the comorbidities, but it's always been clear that there was some connection with people dying from COVID, quite apart from being generally very elderly. Often there's a relationship with other morbidities, and as more stats emerged this time last year, we've been able to delve into that more quickly, more deeply, more accurately. So the point here is that if you have conditions such as diabetes in particular, or just obesity, which obviously connected with diabetes, quite apart from other conditions of pre-existing heart disease or respiratory disease, then you tend to be more likely to die from COVID. So that relationship, from an actuarial point of view, once you have the stats, and we were using stats from Open Safely, which has been a very good sort of multi-factor analysis on that, allowed us to sort of think through, given the sort of the hazard ratios, the risk factors associated with obesity, diabetes, and so on, you could actually work out reasonably accurately the different effect of COVID on those people compared with people in normal health. So if I look at that the other way around, it means that the COVID deaths tended to be people who had a slightly lower life expectancy than the general population due to the disproportionate number of the obese, the diabetics in the sort of COVID deaths pool. So again, doing another sort of U-turn on that does mean that those who survived, the survivor pool has less diabetics, less obese, and also on the subject of less people in the more deprived socioeconomics of quintiles or deciles, who are also generally higher mortality from other causes. So therefore, the survivor pool is lighter mortality than, if you like, the general population was pre-COVID. So it's a sort of strange form of silver lining. And the data we have on that allows us to do some reasonably decent sort of actuarial calculations. We were coming up with a likely lightening of base mortality for the sort of more mature annuity or pension portfolios of in the region of 1 or 2%, which is not a dramatic silver lining for the survivors, but again, it's certainly just about material. And clearly that's a form of select effect, so it'll wear off as most select effects do, but it's it's not something to be aware of. It's again, it's in the actuarial comfort zone as being able to be calculated, probably much more so than the things we discussed earlier, such as the endemicity or the long COVID aspects. And again, as was noted earlier, it's also brought in line with some of the figures we've seen this year in terms of negative excess deaths. So Q2 sort of heavy negative excess of over 10,000. We'd think that's largely due to the forward displacement. And even in Q3 with another wave of COVID deaths going on, if you compare the excess deaths against the with COVID on the death certificate, you still find, sort of looking at the difference between the two, around about 1,000 or so fewer deaths than you would otherwise have expected over and above the COVID deaths. Again, so there's still some sort of negative there, which again would assume is reasonably assume is a forward displacement effect. So overall, there seems to be a material effect. It's very much weighted towards the older ages, as you might expect from the way the figures work. So something to be borne in mind by the annuity pensions side of the audience, and also the protection portfolios.
When you said it was a select effect, do you have any kind of rough indication of duration? Is it a 2 or 3 year max?
Yeah, I suppose we're looking at if in sort of 3 to 5 years sort of wind down or wind up, wind off, run off, one of those.
Okay, thank you, Matthew. Stephen, I know you have a couple of words.
Sure.
Thanks,
Tim. Thanks, Matthew. For me, the full displacement is sort of manifestation of frailty effects. It's in many ways it's the concept that if either the individuals, when they go through some kind of morbidity offence, can tip over to a point of decline, and that's a point of no return, as it were. Now, COVID made that sadly very short and sharp for a number of individuals through the actual COVID virus, but we've certainly seen those kind of frailty effects and forward displacement of deaths as a characteristic of other viruses in the past. Seasonal flu does that in many ways. It was bad flu season can have a 18-month, 2-year lag of onward effect of effectively forward displacing some deaths by causing frailty. So what I suspect we've seen with the COVID is effectively taking over quite a considerable amount of that frailty out of the population, which is, as say Matthew and Tim, will lead to a select effect. For me, the kind of actuarial modelling question is what proportion of the COVID deaths were fundamentally that. There were people who had a reasonable degree, or they had elevated morbidity such that they were close to that point of tipping in the near future, versus actually would have been deaths that have been 3, 4, 5 years out, and it's therefore leaving a more protracted select effect in our residual population. And that, personally, I find quite challenging to get a handle on at the moment.
Yeah, I guess as Matthew said, one of the nice things about this one is you can actually do some numbers and put a cap on it by excess deaths during the pandemic. So it's amenable to analysis, which is not the case for the next question we're going to turn to. So, and by that I mean we'd like to talk about health and social care spending. So, on the one hand, the country has seen a massive increase in its debt to fund the crisis. On the other, there does seem to be an increased appetite for more spending on health and social care. So we're not going to spend time now trying to predict the next 10 years of UK economic growth. We may indeed run a future webinar to cover the specific issue, but it would be useful, I think, to discuss how health and social care spending may affect future longevity improvement. And I know this is something that you've discussed quite prominently in the past. Richard, maybe you could kick us off on this difficult but critical topic.
Yeah, sure. And I kind of guessed, because we're primarily interested in difference in views and how they've changed since the pandemic. I think it's sort of useful to kind of recap what people were sort of saying about healthcare spending before COVID. And I think in particular, my sort of thinking on this was sort of quite heavily influenced by some work done by the IFS, and in particular, I remember sort of Paul Johnson speaking at the Longevity Symposium organised by the profession, probably about sort of 5 or 6 years ago now. And I think he sort of he kind of brought out the point very well that we're going to need very substantial increases in real growth expenditure on health and social care, just to keep sort of still, basically, sort of to keep up with the sort of increasing demand because of the changing structure of the population, the aging population, the increase in demand. And I think he sort of suggested that increases of something like 4% per annum in terms of real growth expenditure on healthcare were going to be sort of needed in the period up to 2050. And if improvements in productivity in the NHS sort of stayed roughly as they had been for the previous sort of decade or so, then that would mean that the amount of money that we needed to spend on healthcare as a percentage of GDP would essentially have to double between about sort of 2015 and 2050. So we'd have to go up from about 7% to 14%. So it seemed to be that prior to COVID, there was going to be a really sort of substantial challenge that we were going to face as a country to be able to kind of afford the sort of increased expenditure on health that we were going to sort of need to have in order to sort of meet the increasing demand for health and social care. So we had a very sort of challenging environment prior to COVID, and there were sort of signs that the NHS was already under strain, sort of coming up to 2020. Obviously now, sort of layered on top of that, and I think sort of prior to COVID, I certainly viewed this sort of challenging environment in terms of funding as being something that almost had a bit of a kind of, potentially a bit of a drag effect on mortality improvements. It was going to be difficult to sustain, very rapid increases in longevity because of improvements in healthcare because of these sort of challenges in funding. I think since COVID, we've now got this sort of additional sort of layer of difficulty sort of added onto this very challenging environment. So we've not only got this sort of aging population requiring, causing increasing demand in healthcare over time. We've now got the issue of the backlogs in treatment, the increased waiting lists, and so on. And obviously, sort of part of the reason for the announcement of increased expenditure on the NHS and social care recently has been in order to sort of address those particular issues. But I think it's what's sort of much being pessimistic, what's much less certain is whether the increased funding will be sufficient not only to sort of meet the additional sort of costs and needs of the NHS and social care sort of system because of COVID, but whether they'll also be sufficient to sort of transform the NHS and the social care system into something that can sort of meet the increasing sort of demands sort of going forwards. So I think that's the kind of the pessimistic kind of view, that we actually had a challenge and now we've got an even bigger challenge. Surely it's going to be difficult to drive, even if there is more spending in the health system, is it actually going to drive more rapid improvement? I think the only sort of optimistic things I would sort of perhaps sort of layer on top of that is that do we have now an increasing kind of political will and a sort of more social acceptance that we need to increase taxation in order to fund increased spending on health and social care, and perhaps that'll be in a sort of an enduring sort of change that will last into the 21st century. And then I suppose sort of the second point is that will there be sort of material and significant sort of upsides in terms of organizational learning in the NHS in terms and how to drive increased efficiency and productivity, perhaps through things like remote appointments rather than face-to-face appointments, which obviously can be very problematic, but potentially you could argue that in order to sort of drive the sort of productivity growth that we'll actually need to allow us to sort of fund the NHS properly in the sort of coming decades. Those kind of changes are going to be sort of required. So that's just sort of funding. If I don't know, I've talked quite a long time already. I don't know whether I should sort of pass on to sort of Matthew and Stephen at this point, or explore this further.
Well, I think there are a couple of points. So somebody's asked the question, which is, so you referred to the 7% spending, GDP spending on healthcare needing to increase to 14%. And the question somebody asked was, how does the UK compare with, say, other Western European countries? Were we catching up, or are we all in the same boat? They all facing massively huge need to increase healthcare spending.
I don't think we're sort of dissimilar to other European countries necessarily. Obviously, it varies a lot from country to country. Obviously, there are countries who spend an awful lot more on healthcare than us, such as the US, but they have a very sort of different kind of system. I think it's not impossible for a country to spend 14% of GDP on sort of healthcare, but if you keep spending on everything else at the same sort of levels, it just means that taxation would have to increase to a sort of a massive extent compared to where it is now. I think I worked at the time. I kind of worked out that to increase 7% of GDP equates to increasing basic rate tax by about 20 pence in the pound. So it would have to go from about 20p a pound to 40p a pound to be able to sort of afford that kind of sort of change in expenditure on one single item.
Stephen, I think you've got a few points.
Sure, I can see Matthew also desperate to come in, so I'll keep it brief, Matthew.
And I just want to comment on Richard's point, but I'll bring this into mine. So please don't keep it brief on my account.
Thank you, Matthew. I was just to add into what Richard was saying there. I think we often get fixated with our spending as a nation on health and care as a percentage of GDP, which is a very natural measure. And if we look at that, we are second almost only to the US. We're very high up on that measure, but not that high on the global life expectancy and outcomes tables. And actually, what's really more fundamental and useful rank those outcomes appears to be the GDP per capita. So, and that comes back to me to a sustainability point. If we're going to actually create sustainable increases in longevity and healthcare, we need to be increasing the amount per capita that we're spending on healthcare. And to do that, I suspect at the moment that we'll find that quite challenging without some kind of growth in GDP per se, so that we're actually spending more pounds per capita affordably within GDP on health and social care. So for me, this question is very much linked to the growth outlook for the UK, and therefore can we realistically divert more pounds into healthcare without it necessarily creating a real budgetary tightening. Of course, we do also need to bear in mind this is a little bit, we are facing a very different situation than a decade ago when we last saw tightening of the belts in the post-2008 financial crisis. We've basically in a very short, sharp shock increased national debt by about 30%, or will have done by the end of this fiscal year, extra $500 billion in national debt. But we are saying we are going to protect healthcare spending more than we've ever done in the past. And I think that plays to a change in national sentiment around the importance of health and social care. I'm happy to expand on that, but perhaps I should let Matthew say a few words.
Oh, thanks. I was just raising my hand, just in response to the question you said had come in, Tim, about where we stand. One of the sort of things I've been looking up just before the session to sort of refresh my memories was that particular point of total health spending as a percent of GDP. So that's total, so government plus private. Where actually they're surprisingly stable. So I was looking, UK is just above 10%. I think these are 2019 figures. So 10% of GDP total health spending, and a huge number of European countries around about that 9, 10, 11%. Obviously, you've got outliers, which is the US is sort of probably above 100% of GDP on their healthcare, slight exaggeration, and Ireland quite low, but it's very surprisingly stable actually, which then makes you wonder where things are differing if there's so much commonality in that figure of around about 10%. And I suppose leading on from Stephen's point, I think there's a lot more sentiment about the importance of the health system. I think there's also an awareness of the inefficiencies in the NHS. So although we might applaud the individuals who have been working their bones off and so on over the pandemic, the sort of structural inefficiencies makes one sort of wonder to what extent we want to spend our entire lives protecting the NHS. So there's, I think, if we were to want to make a quantum leap in the sort of the benefit of the NHS per pound of expenditure, we'd probably need to be looking at some sort of structural reform, which I think from a political perspective is probably pretty much impossible, given the way the UK is sort of works. Obviously, a bit of a personal view there. I suppose it just changing tack a bit, but on the same theme. One of the big questions and I think we've all been grappling a lot of this before the pandemic for sort of 5 or 10 years, thinking through our various different sort of driver-based models, trying to sort of think through how improvements are going to come about from health expenditure, whether from best estimates or also the capital modelling for the internal models and so on. And we've done lots of work on that, I think, across our different organisations. And one of the things about the pandemic is going to completely, not completely overturn those thoughts, but almost require a lot of thinking about how those parameters are going to work, because every sort of pound now being spent, every pound spent in the NHS next year compared with 3 years ago is going to be a completely different sort of form of efficiency. You've got sort of problems now with staffing. You've obviously got the backlog, so all that sort of government bonanza is clearly going to be sort of targeted at the backlog as opposed to sort of solving, if you like, new problems. And we've got this spending on vaccination. It's obviously been you could well argue money well spent over the last year, probably money very well spent. But clearly that's all money which is not going to be not sort of materializing out of nowhere. So all of our sort of thoughts about that relationship between expenditure and longevity benefits sort of would be quite different in an adverse direction, I think, over the next few years. And obviously we also got those diminishing return aspects. So obviously as people get older, then there's a diminishing returns effect. I think also if you're increasing expenditure in a bit of a short-term boost as opposed to anything sort of more gradual or more structural, there's also a diminishing returns effect. If you suddenly get given a wad of cash to spend in your sort of health trust or foundation or whatever, then it's much less clear how you can spend that efficiently compared to the more sort of gradual expansion. I think talking to people in public health in the 2000s, they were saying they're being thrown so much money they just really didn't know how to spend it. So which is also an added worry that we might be increasing the expenditure on the NHS, but doing so in a very inefficient way just to for politicians to reap their political rewards probably.
The life expectancy did increase spectacularly during those.
Oh yes. It's only a very clear relationship, but it's a question of efficiency, really.
Yeah.
So just to try and pin people down before we move away from this topic. So Richard, you had a bit of positive and a bit of negative. The negative is everything's worse than it was before, but maybe the positive is there was appetite for recognizing the need to spend. Where do you fall on trading? Where do you fall on trading those two against each other?
Do you mean sort of in aggregate rather than just in relation to sort of healthcare?
Well, in aggregate, is the net effect positive or?
Yeah, I think. Well, I suppose something we've sort of done in Just Group, actually sort of for the last sort of 12 months or so, is got together a group of sort of internal experts, and we've systematically kind of tried to get people's sort of views on how likely the positive and the negative outcomes actually are. So recognizing that, there is a probability distribution to the sort of potential sort of outcomes, and we can't be certain it's going to go one way rather than the other way. But we just found it quite useful to get a kind of a sense for how sentiment is changing and how different people's sort of views are, perhaps from different sort of backgrounds. So I suppose I would always try and put things in terms of probabilities. I think perhaps because of that sort of exercise. So I think at the moment I'm thinking that if I tried to sort of say 5 or 10 years out, are we likely to have higher or lower mortality rates than we thought prior to COVID? I'd probably sort of say it's about 75% likelihood we're going to end up with heavier mortality rates and about 25% lighter mortality rates. So not symmetrical, kind of more weighted towards the kind of the negative higher mortality outcomes, but still quite a kind of material sort of probability that it could actually be sort of better in 5 or 10 years than we thought prior to COVID. So it's about that kind of sort of weight towards the different kind of outcomes.
Okay, and before we move away from health and social care, Matthew or Stephen, do you have any final points?
I'd agree sort of directionally with if I take the mean, because I guess I like to be more either mean or extremes. I'd agree with the implied mean of Richard's. So those are worse mortality improvements than would otherwise have been the case if we'd been having this conversation 2 years ago, which of course we wouldn't, because this is more of a COVID conversation. But I think the whole thing is being adverse overall.
It is difficult to come away from the conversation and conclude that it's positive, I guess. Stephen, any final points?
I would possibly give a mildly different perspective, in the sense, whilst I'd agree that short term the pressures are very much downward on longevity, upward on mortality with regard to the pressures on our health and social care through the trauma it suffered through COVID. I would probably put a bit more nuanced view, in the sense that I've probably changed the shape of my outlook for improvements compared to where I was a couple of years ago. So probably much more of a tilt on it, with not much reflecting downwards pressures in the short term. But in terms of the health and social care and probably aspect in isolation, I'm probably more optimistic around the medium to long term than I've been in the past, because of the spotlight that's been shown on the lack of elasticity and resilience in our system, and because of the general change in sentiment and willingness to try and do something with it, including anecdotal evidence that within the system itself, the change that was forced by COVID has made people realise it's possible to change the systems. So that resistance to change barrier has in some way been perforated.
Interesting. So you have managed to draw a positive. In a slightly, not in the immediate future, but looking forward. So moving on. So during the pandemic, we saw next to no flu deaths, seasonal flu deaths. Maybe I'll come to you, Matthew. Looking forward, do you think the relatively high flu deaths we've seen in previous years may become a thing of the past, or are we going to lapse back into old habits?
I'm thinking over the medium term, we'll probably be back in sort of similar land to where we've been in the past. As I said, maybe I think very likely we'll have better vaccine uptake, maybe a bit more sort of risk-averse behaviour again in crowded places in the winter, and again, people much more willing now to work from home if they've got a cough or a sniffle, or obviously an empty petrol tank. So that's all going to help reduce flu deaths in terms of normal seasonal flu, but I don't think it's going to be disappearing. So one of the, again, an interesting silver lining last winter was the virtually zero flu deaths for various reasons. I think that's a one-off. Hopefully we won't see a sort of complete reversal of that this winter, but I think we'll be back to a sort of normal-ish but slightly lighter general sort of endemic flu in the future. That's my view. Tim is frozen, but that's another sort of interesting ailment, the Zoom freezing. I don't know if you can hear me.
I'm hoping I'm not frozen.
I know.
While we were speaking, actually, we had a couple of questions back on the health topics. One was, we did say we'd try and capture this, which is socioeconomic gradient. Is there any, in terms of the impact of the health kind of care impacts, is there a socioeconomic health inequality aspect to that maybe we should have mentioned?
Yeah, the work I was just refreshing my mind, and I just can't find the right reference now, but I was finding actually that on the sort of benefit per pound, it was actually the sort of silver lining, I guess, if I'm ever using that phrase, of the bad mortality in the more deprived deciles or quintiles of the population, means that the benefit per pound of extra spending is disproportionately beneficial for those lower. I'm trying to avoid using the phrase lower classes, the more deprived quintiles. So in other words, it's sort of a positive for them if there's increased spending. It's sort of disproportionately positive for the more deprived parts of society. Was my sort of take.
And the other question we had, and it's very straightforward, blunt question, which is, any thoughts on the quantitative relationship between increase in health expenditure and mortality improvements? Richard, you put some pretty stark charts up in my memory about the relationship between those two things.
There are, I mean, there was, yes, there are some charts showing that in the past, changes in life expectancy have kind of shown, in the UK at least, shown a very similar pattern to sort of changes in expenditure in healthcare, from one sort of government to the next. I mean, I think, in fairness, some of that was coincidental. I don't think there's certainly not a perfect correlation between healthcare expenditure and changes in life expectancy. I would see it as being a kind of correlated, but sort of weakly correlated. It's one amongst a whole range of different factors that drives changes in life expectancy. As to exactly how correlated, I'm not exactly sure, but I would, I'm sure it was a factor behind the fact that the sort of improvements in the UK perhaps sort of dropped more substantially than in other European countries in the kind of the sort of years after 2010. But it certainly wasn't the only factor we saw a sort of drop in improvements. So I don't see it as being, I only see it as being sort of weakly correlated and really hard to quantify exactly how much change in expenditure will lead to how much change in life expectancy. Virtually impossible to really do that, given all the other factors involved.
Yes, thank you for that. Stephen, we did talk about behaviour in passing. I just wondered if there are any other wider behavioural changes that may have emerged as a result of the pandemic that you think might impact future longevity?
I think it's probably quite a few behavioural changes. How many of them are going to impact the older generations? I guess many of the people in this call are most concerned about from a sort of annuity book perspective. It's a lot harder to focus on. I'm just pulling out a few though that have struck me. One is the noticeable impact that the pandemic has had actually on savings behaviours, and so given the correlation between general affluence and behaviours and health in later life, the absence of or reduction in savings in the UK as a consequence of the pandemic may well be one tailwind we need to be careful. So headwind we need to be careful about. Another behavioural change for me is we talked about many people there's been a lot talking about behaviours and changing in our modes of transport, working from home, etc. And we did see a sharp shock in terms of pollution changes as a consequence of changes in our behaviour. Now that didn't persist, but what I find interesting from that is that actually the level of change we saw as a consequence of the pandemic and of us essentially socially isolating, of us working from home, that level of change in pollution is the level that needs to be sustained as a percentage change year on year for quite a considerable period of time to hit the Paris Accord 1.5 degree climate change target. So I think some of the realizations of the quantum of changes that we're going to need in society and what that really means is going to be an interesting behavioural change as how we address some of the big systemic issues of the future. Making it a bit more tangible, I do think some of those changes to working patterns will influence the older population. It potentially gives us the ability in a time when the health and social care system is under strain to access greater informal caregiving, flexibilities for individuals who maybe are more able to give informal caregiving in their community with their family as a consequence of more flexibilities around the working day will be an interesting one. But I think the real big behavioural change is really going to be the most obvious tractable one is going to be back to that: how well do we look at the hand and respiratory hygiene in the face of infectious diseases? And coming back to the question that we asked about that, I think the behaviours don't change. Whilst behaviours have changed recently, changing many years of ingrained behaviour, I suspect means that we're going to see this behaviour changes coming through slowly over generations, with effectively the behaviours that have been taught amongst our children and younger adults, and less amongst the older population. The only way I can see that personally changing is if we have another bad winter season this year, and people really see the fact that this is now something that we do as society level need to change. And I think that is a very real risk. I take my lead here from the medical profession, and they are getting increasingly worried about this year's triple spike, the possibility of an influenza season, the possibility of the COVID spike in the winter months, and an RSV, the respiratory syncytial virus, rearing its head again, with people having greater ability to transmit, and the pressures that will put on our health service, and the consequential impacts that might have us on society, and therefore willingness to change behaviours.
Thank you, Stephen. I'll definitely have to get my flu jab. So one of the spectacular good news stories during the pandemic was the development of mRNA vaccines. Given that they have applications potentially much wider than COVID-19, is this positive for longevity, or does it actually mean that funds are being diverted from other potentially more beneficial medical research? Matthew, how do you feel about that one?
Yes, slightly beyond the realm of my expertise, but I could sort of hazard some non-expert conjectures. I think it is positive. So I think one of the problems I saw with sort of pharmaceutical research and expenditure over the last 10 or 20 years was almost like the grain of sand on a beach sort of thing, where every extra billion of expenditure is getting an extra grain of sand of longevity benefit. And I think with the mRNA, it's a sort of quantum jump. So it may not procure many grains of sand, but if it does work with other conditions, maybe even cancer, then that's not so much a grain of sand as just a whole half a beach of mortality sort of disappearing. So what sort of thing if I was setting assumptions directly in relation to those, I might think no change to best estimate, but it's a massive, well, not massive, but potentially something to be aware of at the capital end of a much bigger chance of a major sort of technological leap with mortality.
Same. Okay, so you're falling on the benefits side of that, not the diversion of funds. Probably.
Yes, partly because the funds as having been diverted from sort of direction of travel, which just wasn't very beneficial, other than for the pharmaceutical companies.
Right. Final question. So, Richard, I'll come to you with this first. So we're potentially going through a series of accelerated changes as a result of the pandemic. At the same time, it's difficult to see how this is all going to manifest. So can you comment on what we should be looking for maybe in the coming months and years, or in terms of what might be an emerging signal, or maybe just tell us what worries you most when you're thinking about what might change future longevity trends?
Yeah. Well, I think in terms of what we're sort of looking at, I think Matthew's already sort of mentioned the kind of the light mortality that we saw in quarter two in terms of sort of population sort of deaths, and the fact that it's been sort of heavier in sort of quarter three. I think like in terms of what we're sort of looking for, I think I'd be looking very closely at how mortality is changing, kind of almost like week on week, compared to what we expect it to be sort of for the sort of time of year and by age and other factors as well. There's also data that Public Health England are publishing on sort of deaths that mention specific causes by week as well, which is very useful to look at. And I think just looking sort of very carefully at that sort of population sort of level data as it emerges week on week compared to expectations, I think is is extremely sort of useful and instructive. I mean, actually, my take on the Q3 stuff is actually maybe a wee bit different to Matthew, in that I kind of see it as being almost like surprisingly heavy, given despite the fact that we're sort of going through this sort of period of sort of slightly elevated COVID deaths in the sort of third wave of the pandemic. So my kind of view is that's actually sort of, that Q3 data is really quite interesting compared to the Q2 data, and it's that kind of learning that I would tend to sort of focus on sort of in the kind of the short term.
Matthew or Stephen, any things that keep you up awake at night?
Yes, in terms of signals, I suppose I mean, obviously overall deaths, but I think the thing which I'm concerned we might be getting wrong, and maybe me and Stephen are a bit too optimistic at the start, was around long COVID, and there's lots of research now underway looking at long COVID properly, which hasn't just due to the duration involved, hasn't been looked at particularly well so far. So I think the emerging research on long COVID will be very interesting, very important to keep track of in terms of signals. I guess in terms of keeping me awake at night, I guess I've got two concerns. One is, if from the actuarial perspective, just actuaries sort of just, even though they're supposed to be setting best estimate assumptions, just saying, well, it's, who knows, let's just stay where we are for another year, sort of thing. And I think actuaries should be trying to reflect best estimate and not just sticking with last year's assumption set for the sake of governance ease, because governance shouldn't be sort of making staying an easy option. The biological aspects probably more around the long-term aspects of mental health, which again could be a long-term emerging nasty. Those are the main things. Yeah.
Stephen?
Thanks. So I think the final thought I would give would be actually bring us back to where you started this session, Tim, where you mentioned Richard's seminal paper from almost 2 decades ago when we had the cohort effect. And at the time, this obviously caught us on the back foot a little bit. But ironically, you could look and say many of the signals for that had been there for a long while in the past in terms of changes in healthcare expenditure, structure of healthcare delivery, smoking cessation, etc. And therefore there were a large number of leading indicators that had come through. And for me, I probably take that lesson into this pandemic and say, well, actually, alongside looking at that weekly mortality data and what's coming through, I want to be also having a dashboard that's looking at a number of other indicators, the morbidity indicators, the healthcare spending, the policy spending, human behaviours, to try and get a more rounded view of not just what's coming through in the immediate future, but whether or not the risk factors and the things that will influence and drive future longevity trends are in some way shifting, positive or negative, compared to where we were a few years ago.
Thank you, Stephen. So I think we're pretty much on time. There are a couple of questions that we didn't get around to. I think we may have a separate session on morbidity because that was clearly interesting. So it remains for me to thank our panelists. I thought they were excellent. A recording will be made available, and this is the first in a series. If you've got any suggestions, please contact the MIG or use the LinkedIn details that I think will be on a slide immediately following the session. Finally, thank you for your time. I hope the discussion has proved useful. Thank you.